Hello, everybody. We're back. It is Thursday, July 15th. I have some good news. I have some bad news. The good news is it's 73 degrees outside, sunny, beautiful day as the summer has been beautiful. Bad news is summer is halfway over. So sorry to tell you that. And for those of you who had kids, I'm afraid to go back to school in August. So hopefully if you haven't gotten away, you're getting away soon. So back with Gary talking about the ever-changing world of COVID. I think we last did a video a couple of weeks ago. Things were pretty calm, but it seems like there's something in the air right now. Can you tell me, what's your take on where we're at right now?
As I look back and just kind of reflect on where we've come so far, I see that we've kind of come through this paradigm shift. And that paradigm shift is very important. Where a year ago, when vaccine was being studied, we were hoping it would come out soon. We didn't really know as much about the virus, and so we were trying to make the care centers as safe as possible. Mm-hmm. So without a vaccine, we had shifted patients out and created a respiratory care clinic, and waiting for the vaccine. Now, come forward to the present day, a year plus later, we're at a place where the paradigm is now, with vaccine available and the two best vaccines in the world, we're very protected against the virus, even a number of the variants circulating throughout the world. And so now we're at a place where patients can start coming back to see us because we are much more immune, much more safe, much more protected. And I think now it puts it on the playing field of influenza. It's like we have a great influenza vaccine this year, and the risk of getting the flu is super low. So I see that paradigm shift is very important, and we're making responses to that. Pre-vaccine, we had to do something different. Post-vaccine, now we can be much safer with patients coming back.
So the PD is always good at hyperbole, and sort of the front page today is, explosion of COVID at a homeless shelter, 59 people infected, some of them had vaccine. Is that what's different?
Well, certainly the Delta virus is circulating throughout the world more. And actually there's a Delta plus because it continues to change. The evolution of this virus is much slower than the influenza virus. That's the good news. So this virus doesn't mutate as quickly as the influenza virus, and we're all used to the influenza virus. But the Delta strain is clearly more contagious. And so let me show you some data from public health, because we're seeing an uptick of cases in the ER and in the hospital. The first slide comes from Sonoma County Public Health, and I put a little arrow there to show you on the right-hand side where we've seen an uptick of cases. Not only positive cases, but also patients coming into the hospital. So hospital cases are up a little bit, and what I'm seeing anecdotally is I'm seeing a younger cohort of patients in the hospital. Now let me show you the next slide. The next slide is, who's getting infected? Who's testing positive? And this slide shows that it's a younger cohort, where a year ago, before vaccination, the elderly were very infected and it was very dangerous to them. Now we're seeing younger patients coming into the ER, into the hospital, and so far 99% of these cases, maybe there's one, maybe there's two, but in our county, these are all unvaccinated people. So I think at this point, to be unvaccinated in the pandemic with a more contagious strain is clearly a more dangerous situation. So the vaccine campaign is really going to be the hallmark, I think, of what we do locally. Let me show you the next slide. The next slide kind of illustrates that. This is from Sonoma County Public Health, and this just shows you the case rate by vaccination. And you can see that the red or the orange line at the top is the unvaccinated folks. And the blue line are those that are testing positive if they're vaccinated. Remember, the vaccine, the mRNA vaccines, 95% effective. So 1 out of 20 people who get that vaccine can still be prone to getting infected, but not getting ill. And we're seeing that in this graph here. But it's the unvaccinated people, 99% of them that are in the hospital are unvaccinated.
Okay. When I read further into that article today in the paper, when it talked about vaccinated people were infected, it turns out they all received the J&J vaccine. So we had a different vaccine, but the Delta virus is out there. Are we still safe with the vaccine we received?
It's a good question. So yes, so I'm going to answer that carefully. One is the mRNA vaccines, the Pfizer and the Moderna vaccine, are the best vaccines in the world. So we're very fortunate here to have the two best vaccines in the world that are maintaining their protection and their safety and their immunity to even the Delta strain and even the Delta plus. The J&J vaccine is still good, it's just not great. And so the J&J vaccine doesn't offer you the same protection as the Delta. I'm going to show you another interesting slide. And this kind of brings home the vaccination efforts. So this comes from the Lancet. It kind of is a historical slide that kind of tells you that originally the R0 number, or the basic reproductive number for COVID, when it first showed up on the scene was 2.5. That means that if you are in a population of people where no one's vaccinated and everyone's vulnerable, one infectious case can result in 2.5 more cases, and those go on to 2.5. Now, the Alpha variant, which came out of the UK, was 60% more was 60% more contagious, and that took the R0 number, the basic reproductive number, to 4 to 5. And the Delta strain has an R0 number probably of 7, and we're seeing that. I see that in some patients in their histories, where before someone would say to me, "Yeah, my daughter, my son was sick, and then a couple people in our house got sick, and maybe more than half got sick." Now I'm hearing, and recently a case in the hospital, that there was a barbecue, there was one person that was sick, and by the end of 3 or 4 days, both houses were completely sick. And we're seeing a much more contagious rate with the Delta strain. If you have a more contagious virus that has a higher R0 number, you need to vaccinate more people to reach herd immunity. That's really important. So where herd immunity might have been 70% with the original strain, we're probably pushing 85% or higher with the Delta strain. So we're lucky to have 2 vaccines that work in the United States. And these mRNA vaccines are terrific, but we're going to have to vaccinate more people with this terrific vaccine. In other countries where they have the adenovirus platforms, they're not coping very well. Russia, China, Malaysia, Brazil, they're all struggling with vaccines of a different platform. So I think in the US, we're incredibly fortunate to have these vaccines, and that puts us in a very safe place.
You know, I think about it, we are on a broader level, we are very fortunate to live in America because we ended up getting the right vaccines and we got them rapidly. I mean, the rest of the world is still waiting. But so I hear you saying the Delta virus is out there, it's much more contagious. But what about us? I had the mRNA vaccine. How safe am I in light of the Delta variant?
So I think everyone's kind of wondering that. You know, if I got vaccinated and I got the right vaccine, I got the Pfizer, I got the Moderna, is my protection okay? And recently there was some data released by CDPH. So this is California data. I'm going to show you this other slide. In this slide, from January 1st to January 7th, over 20.4 million people were vaccinated. And the vast majority of these people in California received the mRNA, Moderna, Pfizer vaccines. There's a small subset of this that is the J&J vaccine, but they didn't tease out that data. Of those 20.4 million vaccinated people, the State Department of Health recorded 10,400 symptomatic patients. So that takes you
breakthrough infections.
Yeah, so these are breakthrough infections
okay.
after you got vaccinated.
Okay.
And that comes to about a 0.053%. So 0.051% of the people became infected after vaccination. If you look at that 0.051% of people, about 7.8% needed to be hospitalized with that breakthrough infection. About 92% did not. 92% had no symptoms, and they were sequentially tested for other reasons, like maybe preoperative reasons, or they're flying, or they're going back to school, or they had very mild symptoms. And there were a couple fatalities, and the fatality rate of a breakthrough infection is 0.0135.
Of the 10,000. Okay.
Of the 10,000 cases.
Okay.
So incredibly safe. Those breakthrough numbers are so low, and that's at a time when we had the Delta variant circulating, and that's kind of muddy data because the J&J vaccine is kind of mixed in there.
Okay.
So I think that if you're in an office and you're seeing patients who may or may not be symptomatic with COVID, and you've been vaccinated, and now you put on a mask, as we all should be wearing every day, your risk is extraordinarily low.
Okay.
And that's why I think it's more dangerous for us to face the flu unvaccinated than it is to face COVID vaccinated.
I just want to clarify, because I thought I heard you say this is from January 1 to January 7.
Oh, no,
this
July 7.
July 7.
July
so this
7,
is very
yeah.
current data.
Yeah, so this is good. It's
Okay.
robust data, right?
So it
it's
includes some Delta variant.
In 6 months of this year, it includes a lot of the other variants, including the Delta variant,
Okay.
what is circulating more widely.
Okay. Now, so game changer is the vaccine. But what else have we learned over the last 15 months? We've been doing some simple precautions. We've been wearing masks, we've been hand washing, we've been using social distancing. There's got to be something from that. What have you guys seen in the hospital utilizing those precautions?
So, I mean, imagine the symptomatic patients that have come into the ED, into the hospital, into the ICU, and of all of that, we've had one person in the ED who might have gotten infected from work. We've had a number of people infected outside of work, which is really where the danger is. You know, if you're not wearing a mask at Costco, Lucky, Safeway, a baseball game, you know, there's a risk there. But in the hospital system with masks, hand washing, and diligence, one simple mild case in someone.
And that's been our experience in the foundation. I tallied up in the last 15 months, we've had 650,000 encounters with patients utilizing the same simple precautions. And we have had one work-related transmission, and it turns out it was somebody who caught the virus from home and was carpooling with another employee, you know, or eating lunch in the break room, and they got it. So same experience from those simple precautions.
Right.
And you know, I think there's something else that contributes to these great success rates and the fact that we can feel so safe. And I looked at our demographics, our patient population at Smugger. At Smugger, we take care of about 120,000 patients, which is about 20% of the county. The county of Sonoma had 30,000 COVID infections this last year. We had 800. So we're taking care of 20% of the population, yet we had less than 3% of the COVID cases in the county. So there's something about our population that says we just don't see much COVID, and there's so many different variables that could account for that, but that's just what the numbers show.
Yeah, that's the data.
Yeah.
Right.
Yeah. So you talked about bringing patients back. So how are we planning to do that?
So I'm going to show you a slide that kind of boils this down. This is kind of high level. There's probably going to be a lot of questions in the weeds, but I want to just kind of make a couple general points. So kind of an update. The respiratory care clinic, we closed it 2 weeks ago. So that's old news. And it's been going great with the close. And I want to thank Sean and Jonathan and a lot of people who put a lot of hard work into standing that up, and for Aaron for support of that. The same-day clinic is up and running. So the same-day clinic is still the same-day clinic, and soon it'll be moving back to Airway, and we're kind of happy about that. Healthcare workers should still be wearing masks in all care centers. So that hasn't changed. We're still wearing masks in all ambulatory and hospital healthcare centers, and that's a CDC guideline supported by the Public Health Department. I personally think that unvaccinated healthcare workers should think about wearing an N95 and or a face shield. I think that's important. Unvaccinated healthcare workers, if you've chosen to do that, I think you do put yourself at risk. It's like driving down the freeway without a seatbelt. So all patients must wear a mask when they come into our care centers. That hasn't changed either. So patients should be wearing masks, and I think that's imperative. And then I think bringing back patients into our offices for routine care, we're already starting that. That's already going on. It's happened in my office, happens in cardiology, happens in many of the primary care offices, and we need to recreate the norm, knowing that we're doing that in a safe environment. So we've had some strategies, and I'm just going to outline some of the high point strategies. One is that patients should be self-screening with posters in front of the offices. We found out like in the MOB, the building manager took them down. We got to put them back up. I've also asked, and Aaron supported this, that just don't put the posters at the entrance of buildings, put them in the waiting rooms. So patients have to ask themselves these questions repeatedly. We also need to have masks available for patients at the entrances. Now, patients with overlapping COVID symptoms, because right now with seasonal allergies, with other viruses transmitting, patients with overlapping COVID symptoms should be escorted into an exam room. We don't want them waiting in the waiting room. Sometimes that will happen, but it should be the rare time. The next thing is the overflow of patients. Overflow patients with no available PCP appointments should still go to the same-day clinic. And that's kind of what we did pre-COVID. So we're getting back to normal there. So we're not using the same-day clinic as a respiratory care clinic, but we're using it for overflow if appointments aren't available. At a minimum, if you're seeing someone with overlapping symptoms of COVID, you should be wearing an N95 mask and a face shield. And if you follow CDC guidelines, they talk about gowns and gloves, but I really think that the money is in the N95 mask and with the face shield there. And providers will providers always perform their exams, but in addition to that, the provider is going to be the one who's going to be doing the NP swabbing if they think that's indicated with a symptomatic patient.
So from a provider's perspective, they're going to enter the room and do their usual clinical evaluation. and in the event they think it's warranted, they're going to do it. Now, some people have asked, why is the provider doing the swab? It's a nasopharyngeal swab. It's mid-turbinate, so it has to go back a little bit, as opposed to an anterior, which a medical assistant can do. And we actually checked with the California Nursing Board, and an MA is not allowed to do a mid-turbinate. So it's going to be the provider has to do that 3 to 5 second swirl and put it in the bag. It really shouldn't slow them down, and we're all capable of doing that. I had a few other questions. In fact, Renee Armstrong sent in a few questions. I thought we could hit off some of these easy ones. One was about room turnover. With simply wiping down the room they're doing it for every patient, but particularly patients who have overlapping symptoms. The rooms are wiped down, and the rooms can be used right away.
That's right.
We don't have to have a turnover. Now, Renee asked about, are we able to use nebulizers for our asthmatic patients? And yes, we can do that. The only difference being that room has to be wiped down and contained for 30 minutes. So it needs to be a 30-minute interval after using a nebulizer.
Gary, that's if you think it's a COVID patient. Right.
That's true.
If it's not a COVID patient, it's someone with COPD who's just having a flare because they mowed the yard, then you don't need to lock the room down. If you think it's a PUI and you're testing them for COVID and they needed a nebulized treatment, then you close the room.
Okay. Our specialty office is open. Yeah, we're all open to all of our patients once again. Are we on the same trajectory as all of Sutter? Yes, indeed. So this is Sutter-wide. Sutter has prepared everybody. Actually, there's been about 6 weeks of work that's gone into this in the background, setting up workflows and getting prepared. But all the offices across Sutter are now entertaining all patients and providing usual care in this, what we call, new normal situation.
Yeah, I don't think there's a respiratory care clinic that's up anymore.
No.
I think they're all closed, So I want to bring up one point. What about, and I'm just going to kind of put this out there, because I think this is what people are wondering about. What if I'm a provider? I walk into a room with a surgical mask, and the patient was supposed to self-screen twice. And I get in the room and they're coughing, or they've got a fever and a URI. How safe am I? If you're vaccinated and you're wearing a mask and you notice that in the room and you wash your hands, step out, put on an N95, your risk is negligible. It's less than that 15-minute window. They're not doing an air size generating procedure. The patient's wearing a mask, so they're not coughing on you. They're coughing into their mask. That scenario for a vaccinated person is very, very low. That scenario for an unvaccinated person, we don't know that, even if everyone's masked. And I think that's where we want to make sure that even our staff and other patients, if they're not vaccinated, get vaccinated.
So to kind of summarize, the vaccine's been the game changer.
Yeah.
And that's what makes us feel comfortable and safe to see patients.
That's right. And so much so, Gary, that I think it's today or tomorrow, UCSF is mandating all of healthcare providers at UCSF must be vaccinated. Stanford's going to follow within the week. Sutter's thinking about their position on that. They're probably going to go in that direction. And I really think that that's really imperative. We never thought we'd have such a safe vaccine. We've never thought we'd have such an efficacious vaccine. Yeah. And I think that there are rare cases of side effects, rare cases of toxicity, but we've been fortunate to have the two we have now.
Yeah. I've talked to quite a few people about this change, and I've seen the vast majority of people are fine with it. But I noticed also that the people who have worked in the respiratory care clinic, they're perfectly fine with it, and you've been in that environment.
No. So, certainly I'm not nervous anymore, and I think a lot of the folks that have worked with Sean in the respiratory care clinic, they're comfortable. And I think for the providers that haven't had that experience with the virus, I was nervous at the very beginning. Their nervousness now is very normal. It is normal. I was very nervous. The first thing I thought about at the very start of the pandemic, I thought about my kids, as everyone does. And I thought about, should I even go home? Should I leave my clothes in the garage? All those thoughts that a year ago seems like 10 years ago. So I do think that providers that aren't as used to taking care of patients with COVID symptoms, I think there's going to be a little bit of an adjustment period, and that's where we need to lean on our colleagues. We're lucky to have a really strong group. People care about one another. Ask someone next to you that's been in the RCC, what was that like? And pretty soon, it's going to be normal. Pretty soon, we're going to go back to this is just like influenza. Not like measles, not like chickenpox.
Good. I'm going to shift gears a little bit, because knowing that the vast majority of our county is vaccinated, knowing that we're safe, we need to think about what we can do for our community. So I have one last slide which talks about vaccinations, because really I think our focus should be on getting the rest of the patients vaccinated. So you can see on that slide where vaccines are available. We at Sutter are not doing vaccinations right now. It simply came down to a lot of wastage with the mRNA vaccines that come in vials of 10 and 15. Once you pull one dose out, you have to use it within 6 hours. And our demand was so low that we started to waste vaccines, so we shut those down. We will probably, or we're investigating having vaccines available in pediatrics, especially if a vaccine is approved for those under the age of 12. But as you can see from this list here, it's widely available, same day, a lot of drop-in places. If you can't remember any of these sites, you tell your patient just to Google Sonoma County COVID vaccine. It takes you right to these sites. Very easy to find vaccines. So that is our job right now, is to get the rest of the patients vaccinated.
Gary, something my MA is doing, and I'll just give a shout out to Rosa, is that in the ID clinic, people expect to get every vaccine they want. And we don't have the COVID vaccine. And so what she'll do is she'll just make an appointment for them at CVS or another pharmacy, and they'll go there the same day. So it's been a really good service. Yeah. So I think that's been a way to get patients vaccinated and not have that waste of vaccine.
I think that's the most important thing we can do for our community, our patients, for us, and our families. So, well, thank you for your time. I hope that was helpful. If questions come up, feel free to reach out to Gary or I or any of the directors, managers, supervisors, or your site leads. So thank you.